So I'm going to talk a little bit about what I think is going to be maybe a bit of a controversial topic, but these are my disclosures. And special thanks to the Focal Therapy Society for the invitation. So let's talk about what's next. And we've talked a lot about imaging so far, but maybe we can kind of start with where we are. We're probably in a sea of acronyms right now, but a sea of acronyms and hashtags that help us understand a little bit about what's happening. So we've got PIRADS version 2.1, which is the current standard that people are utilizing in terms of reporting. We've got the joint statement from the SAR AUA, which talks a little bit about the use of multiparametric MRI, especially in the setting of negative biopsies. We've got new ASCO guidelines talking to us about where MRI falls inside the workup of the patient with prostate cancer or suspicion of prostate cancer. We've got compelling data like promise and precision, and we have hashtag MRI first on Twitter. Right? So the fact of the matter is we have a series of acronyms that help us understand that MRI is here to stay. Now what the question is, what's next? Well, the first thing we need to basically say is that one thing that has been uniformly talked about over the course of the couple days of this conference is that you need high quality MRI. And we need much more consistent study performance, because if you ask anyone in the audience today, what is the most critical step in focal therapy, it is identifying where the tumor actually is and what its margins actually are. So we need to standardize study performance as well as interpretation across multiple settings. This cannot be restricted to academic and major centers. It's physically impossible to see all the patients that we need to see inside of those centers alone. And so what's required to get this beyond an academic pursuit or a major center pursuit? Well, the first thing is the concept of at least adherence to some concept of technical parameters for performance of an MRI. And so the PIRADS committee has given us some technical parameters. They're not perfect, but they're a good start, especially for those people who are looking to try and build prostate MR practices. What we need is robust quality improvement programs. I'm going to put a pitch in for this. I think one of the things that we need to understand as radiologists is, are we getting the answers right or wrong? One other thing that might be required here might be potentially things like site designation to say who should be allowed to do prostate MRI and have they achieved a certain level of quality to ensure that we're getting the right answers for your patients and for our patients. So with regard to adherence to PIRADS version 2, this is something that has been studied in the literature. I'm just going to share some results from one paper that came out of the NYU group in 2018. So they looked at 107 centers, kind of a cross-reference, section of centers across the country. And what they basically found is that overall, there was relatively low adherence to certain parameters of PIRADS, specifically the T2 frequency resolution, the diffusion-weighted imaging field of view, and the DCE temporal resolution. And what they basically said that the adherence was overall higher at teaching institutions, but one of the punchlines of the study basically came up is that the standards warrant greater community education. And so when you see something like this, you want to ask yourself, what is the impact of not following technical standards? The fact is, each of us in our clinical practices sees cases like this, one of the most notable examples being the DWI field of view. When you see a prostate MRI and the field of view for the diffusion-weighted imaging looking at the ADC is this wide, showing you the entire pelvis, you really have to ask yourself, does the person doing the MRI know how to do high-quality prostate MRI? And that's one of the key things I think that really comes out of a study like this. And there have been others who have shown similar issues with adherence to PIRADS version 2. So what prevents greater adoption? Well, one of the things that's interesting is that, especially as we talk about it in here, the demand for high-quality prostate MRI is vastly outpaced by the ability for most to provide it. And so you ask yourself, why does that happen? Well, this field, though it's been around for 30 years, really has taken off in the last 10. And so many radiologists who you work with have not learned this technique in their training programs. So you have to train an entire generation of radiologists to perform and interpret prostate MRI at a very high level without sacrificing quality or patient care. And that's challenging to do unless you have a desire to actually get better. So how do we train this group of radiologists? Well, the first thing we need to understand is there a problem? And that comes from understanding, when you look at an MRI, is this a good MRI or not? Right? You need to be able to see that yourself as a referring clinician. The referrers need to demand high-quality exams and quality reads, because they need to be able to say, not having the high-quality reads or the high-quality exams is preventing me from making the decisions that I need to make for our patients with regard to treatment selection. This requires referrers to know what to ask for and know what to look for with regard to the exams provided by their radiologist, and demanding more from what they could be getting. And what does it require from a standpoint of the radiologist? It requires radiologists to really take ownership of something that is a new field. Many of us who are inside the field of prostate MRI are not trained in it in residency, not trained in it in fellowship, and is something that we've all had to learn. But the one consistent thing in all of life is change, and we have to be able to be willing to make those adaptations. So we in the radiology community have created a series of hands-on courses where there's much of hands-on learning that you get a chance to do, like what we did yesterday. There's an extensive development of online education, and there's the concept of in-person mentorship by visiting and being with other radiologists who are performing high-quality prostate MRI. And the critical need for feedback. So this is something I really want to talk about. This feedback loop is something that I think is going to be critical for anyone who wants to be successful in prostate MRI to do, and also successful collaborations are going to be built out of this as well. So when we perform the MRI, we have to do that at a high level. We have to read and segment the MRI. We understand that there's some variability in PI-RADS. It's certainly not perfect. The concept of joint review of the images and segmentation, probably not required in every case, but certainly required in those cases that are maybe a bit of a marginal situation for biopsy. Performance of the truss fusion and biopsy, and then most importantly, some kind of review of concordant results and discordant results. As Dr. Pinto told us a little bit about this process today. In regards to the critical need for feedback, one of the things that I say as a radiologist that I feel, and I try to impart to the people that we work with, is that this need for feedback is absolutely essential because it is not important for us to be satisfied when we're right. All of those referrers who I work with in the audience know that I say a lot, if we're right, that's great, I'm happy to hear that. If we're wrong, we need to hear about it. We need to understand why are we missing the pathology that is there. We have to be willing to be told that we're wrong and frankly demand that we're told when we're wrong. And the reason is because misses allow us to learn and adapt. I learned more from the cases that I missed in the first years of our practice and the cases that I missed today than any of the cases that we hit. You may have noticed me looking, keenly over the screen here when we were talking with Dr. Choiki's talk, looking at what those PI-RADS 3s look like and try to understand which PI-RADS 3s are going to turn to be cancer, which PI-RADS 3s are going to turn out to be benign or inflammation. These allow us to find our blind spots. This is how we learned about anterior transition zone lesions. The fact is we would miss them consistently before because we didn't know where to look. And now we know, and everybody in the audience knows, I show multiple negative biopsies and PSA that's rising over the course of time, and everybody in the audience knows it's an anterior cancer. Well, the fact of the matter is we didn't know that some period of time ago. These are critical for internal peer review. PI-RADS helped us reduce the variability, but we're not done yet. There's still an ROC curve that comes with PI-RADS, and we need to be able to look at internal peer review. This is something that we do in our clinical practice between our group of radiologists. And they build accountability to referrers. Nothing says that I want to work with you, then please tell me when I'm wrong, right? And this is a critical aspect, and I feel very lucky to have a group of collaborators that we interact with who do this and continue to have this accountability for us. So what do we need in the future for MRI to continue to be accepted and utilized? We need higher consistency of imaging and reporting. We need better biopsy guidance. We're not there yet. We need improved therapy planning. We need mpMRI-based algorithms for treatment selection and metrics for active surveillance, specifically to stay on or come off. And we need to confirm and establish the role of mpMRI pre-biopsy. It is still the only time that you take 12 samples out of the gland without having any visualization ahead of time. So to summarize, the technology's here. We need to know how to use it. I'll give the caveat that you ask your radiologist how old their MRI scanner is and what field strength they're using. If you're outside of 5 years with a 3 Tesla scanner, you might need to ask yourself, do you need a better scanner? And we should press the vendors on this as well. The fact of the matter is there's been a lot of attention paid to other parts of the body, and I've spoken to radiologists about this, but not as much attention paid to the prostate. And we need to basically push the envelope a little bit to get better reduced field of view diffusion sequences, better high-quality T2-weighted images, and continue to improve our DCE. Developing the community expert reader is going to be critical for widespread adoption of MRI. We are not going to be able to provide this service only in the major academic centers. It's going to have to be done at a high level in the community. And this is the concept of site designation, perhaps, with the setting of the ACR. And really, there's only going to occur if we have significant demand and high expectations from our referring collaborators, and really a greater amount of collaboration with the radiologists. The thing that is interesting about this meeting is I suspect that most of you in the audience have very strong relationships with your radiologists. That is a unique situation, and that's something that we need to grow beyond the walls of this meeting. And I will tell you that radiologists are only going to be good if we're not going to be afraid to learn from our mistakes. So thank you very much for your attention.